So again, I think we really have to think about who are the higher risk patients, and definitely those patients with the larger tumors and the positive lymph nodes are patients I would think about for this.
We've got DB11 now, it's cooking. We're eventually going to get things like the event-free survival, EFS rates, and the OS rates. But what are the current benchmarks we got to get above to make this a positive trial? Like maybe you can tell me a little bit more about what we get out of our current TCHP in terms of PCR rates, EFS, and where are we benchmarking and what do we got to exceed with DB11?
Sure. So, what I think we see in the best possible case scenario with our current neoadjuvant trastuzumab, pertuzumab containing regimens is a PCR rate in the high 50s, low, possibly 60%. So that's really where we're looking at. We know the PCR rates are higher in the ER negative, HER2 positive patients. So on the DB11 trial, we did see a significant increase in the PCR rates for the entire group of patients. The delta there was 11% between the two groups. And specifically in the ER negative patients, the PCR rate was even above 80%. So I found that to be quite remarkable.
Yeah, and benchmarking is a little hard because those studies truly in the prior era in the neoadjuvant setting were set up to then allow us to do a proper adjuvant trial, right? That's where we get affinity. Those days are kind of long gone because we now know we can get EFS and OS that's meaningfully different in the neoadjuvant setting long term. So yeah, we'll see how this plays out. We're flying a little blind in this regard, I think. So we've talked a little bit about all these benefits from potentially getting a DB11 type approach. But are there patients that maybe you wouldn't think about this, or is this a one-size-fits-all option?
Yeah. So again, this was a trial more directed at the high-risk patients. So the patients either had to have large tumors, T3 or higher, and they could be any nodal status in that case, or they had to be node positive. So I think we do have to be pretty selective about the patients we're putting on this trial. And I think we're used to that in clinical practice because we do know that we have a de-escalated regimen like the APT regimen, which some of us are giving adjuvantly or neoadjuvantly using one chemo drug. So again, I think we really have to think about who are the higher risk patients, and definitely those patients with the larger tumors and the positive lymph nodes are patients I would think about for this.
Yeah, I mean, in the truest sense, those low risk patients, the small tumors, node negatives, if it ain't broke, don't fix it, right? We're talking 8-year OS rates that are astronomical with single low digits of recurrences and deaths. So it's hard to make that better with a much more toxic regimen.
Yeah, I think we just have to make sure we're not under-treating but not over-treating as well.
Yeah, that's precision medicine at the core, right?
Exactly.
All right.